Hello, thank you for allowing me to present to you today on improving maternal mortality in Afghanistan. Currently, 1 in 11 women die during pregnancy and childbirth. That's 396 deaths per 100,000 live births. Afghanistan is ranked 28th out of 184 countries, from worst to best on maternal mortality. This is caused by a number of factors. One of the biggest is the lack of skilled health professionals present at births in Afghanistan. Currently, 38.6% of births are attended by skilled health professionals. This is due to a couple of reasons. The first is due to the geography of Afghanistan. It is very mountainous, which makes it difficult to travel either to hospitals or for skilled health professionals to travel to their women that they are treating. The second factor is the conservative culture in the country. Culture doesn't allow male physicians to see female patients, and many female students don't complete their education, so there are not very many female doctors. This reduces the number of potential skilled health professionals that can see women. Another factor is that the culture encourages early marriage, childbearing, and having many children. Each birth a woman has increases the likelihood of negative outcomes such as hemorrhage leading to death. My socio-ecological model discusses many of the same factors that I just talked about. One of the things I really wanted to focus in on was the policy level. In 2003, Afghanistan implemented the basic package for health services and the essential package of hospital services. These services cover a number of things. Some of the things include maternal and newborn health care, immunizations, nutrition, infectious diseases, mental health, and medication coverage. What this shows is that there is financial coverage for the services, so economics is not the main issue. The main issue are those cultural and those environmental factors that we discussed previously. My first recommendation is to increase the number of female teachers through a teacher training program. Having more girls educated means that more women can become healthcare providers. Additionally, women who are educated will be better able to make their own decisions regarding contraception and birth spacing. According to the Afghan mortality study completed in 2010, women with secondary education were nearly twice as likely to report using contraception than those without education. The initial goal would be to train 400 new teachers. This is based on the fact that there are 398 districts in Afghanistan, and so I just rounded it up to potentially have at least one new teacher per district. My initial baseline data, will come from USAID and the Ministry of Education in Afghanistan, who are already collecting data on the number of children who attend school. Once teachers are trained and placed within their new schools, we can also survey them on their satisfaction with the training program, which will allow us to evaluate and make any changes necessary for continuing training teachers. In the long term, my goal is to increase school attendance for females in Afghanistan. Currently, only 39% of girls attend school, and obviously the ideal is to have all women be educated. My second recommendation is to have a program to improve positive perception of contraception and increase child spacing in communities. This is based on a small pilot program which took place in only 3 districts in Afghanistan. And rather than only working to educate women, this program recognized the cultural values and worked with husbands and religious and community leaders as well. It focused on a very scientific basis for contraception and birth spacing, showing that as increasing birth spacing will help their wives and the women in their communities live longer. The pilot program found an average increase of 25.5% in the number of women who are using some form of contraception. My goal for this program is to increase contraceptive use by 20%. This is slightly lower than in the pilot program. This is because the pilot program was only in rural areas. As you can see in the chart here, urban women are already using contraception more than rural women. So when you are averaging out the results from urban and rural women, I anticipate that it may be slightly lower than just rural women. In the long term, the goal is to increase the space between births and, of course, to see reduced maternal mortality. The last program will work to train midwives through a midwife education program. This will increase the number of skilled health professionals who are available at births. Women from rural communities can be trained and then return to practice in their communities, helping many of the women who cannot reach hospitals or be reached by other healthcare professionals. This will be an 18 months program based on similar programs in other similar countries. The goal of the program is to have 400 new midwives trained, similar to the teacher training program. The intermediate goal is increasing the number of skilled birth attendants who are available to be present at births. And in the long term, the goal is to see a reduction in maternal and infant mortality. Currently, as you can see in the chart, presence of skilled health professionals at rural births is much lower than that at urban births. The top line is urban births, the bottom line is rural births. So it's very important to ensure that we get women from rural areas trained who can practice in those areas. Long term, this would lead to a reduction in maternal mortality as skilled health professionals, aka midwives, will be present at births and they can react to and prevent problems such as hemorrhage during birth. There are a couple of barriers and challenges that I anticipate. The first is cultural challenges. I think that there may be some pushback from some of the community and religious leaders who do not want to participate in the contraceptive education program. I am also anticipating some challenges just based on the environment and geography of Afghanistan. In order to get rural women trained, we need to be able to get them from their rural communities to wherever the training sites are that we have set up. So it will be a lot to consider to ensure that we have methods for them to get there, places to stay that are safe, and choosing locations that work best depending on the communities we will be working in. We will also need to be able to get health educators into the rural regions, so that presents kind of the similar challenges, but just in the other way. Here you can see my logic model. I discuss most of what I talked about in this presentation. Inputs include things like training materials, funding, and community health workers. Outputs are to create the training programs, to recruit women, and to provide the education. And then the goals are all of what I mentioned in the rest of the presentation, ultimately to reduce newborn and maternal mortality. In conclusion, I recommend 3 interventions: training female teachers, community education for the importance of contraception and birth spacing, and training female midwives. Thank you for taking the time to listen to this presentation.